Mastocytosis is a clonal disorder of mast cells. By clonal, I mean that there are abnormal mast cells that are produced by the body because of a mutation. And most patients with mastocytosis have a single point mutation, which we've recognized as being the c-KIT D816V mutation in the majority of patients, over 90% of patients, which means that patients who have that mutation, they have an increased division and proliferation, growth of mast cells in various organs in their body, and that's mastocytosis. 80% of patients really have what's called cutaneous mastocytosis. That's mast cells in the skin, these clonal mast cells, that present themselves at various types of rash or lesions. And they can be either small or they can be quite widespread over time, and they can cause symptoms. And then 20% of the patients to have what's called systemic mastocytosis, where they have these abnormal mast cells in their skin and in other organs. And usually those other organs are lymph nodes, liver, spleen, and in the gut as well. %20 of patients with mastocytosis will have systemic mastocytosis. It's a mouthful, so I'm going to call it SM because we're going to talk about the categories. But essentially, it means that the majority of patients will have some sort of skin, cutaneous disease, and then they have these abnormal mast cells that infiltrate or grow in various organs. And the main organ that we often see get larger is the spleen, the liver, in the gut as well. And definitely in the bone marrow, because it's the bone marrow that's one of the organs that causes division of these mast cells. So we tend to use the bone marrow to make the diagnosis. To confirm the diagnosis of a systemic disease, we have to prove that those mast cells are outside the skin as well, within the system of the body. And that's how we make the diagnosis. And then we have to prove that they are clonal. And if you have to split it further, which we tend to in clinical practice, we split it into non-advanced, which is disease that isn't very aggressive enough to cause end organ damage, disease that causes symptoms but doesn't damage your organs, your spleens, to cause abnormal blood counts. And the majority of those patients have indolent disease. Indolent just means it's very slow growing. And then the other end of the spectrum is patients who have advanced disease, and they fit into categories of aggressive SM with an associated hematological neoplasm, and mast cell leukemia. And the difference is that those patients have end organ damage. They either have a big liver or spleen, they've had their bone marrow infiltrated by significant numbers of mast cells, and they have abnormal blood counts. It's really, really vital that we get the diagnosis right, that we go from indolent to non-advanced to advanced. But actually getting the original diagnosis right is really important to move from cutaneous skin SM to SM. And so normally the biopsy is done, which is a bone marrow biopsy. But what we need is some evidence that we've got these abnormal mast cells. And there are classifications called the WHO classification and then the International Consensus classification. Those have been there since 2000, and they've been improved each time when we find out more about the disease. So currently, to prove that you have SM, we have to have a bone marrow as the example I'm going to use, but I've had gut biopsies sent to me to prove it. And what we need to demonstrate is that you have abnormal mast cells which are spindle-shaped. They stain up for what are called antibodies. So we look specifically for antibodies that tell us they're clonal and abnormal. And then we look at tryptase levels of above 20 in most patients, because tryptase is a disease marker in mastocytosis. And we also then look for the c-KIT mutation. We have to have evidence. And we need, of those 4 things, 3 to make that diagnosis in the WHO. And then if we've got that, we can then say, yes, this patient has got systemic mastocytosis. So let's look at the patients with the indolent disease, which are the non-advanced disease, which are the majority of patients. And if you've got skin spots, you've got skin rashes, depending on the degree of the skin rash, patients will tell us that they've got itching of their skin, and that can be horrendous in some patients. They can come up with wheals. They can come up with what's called urticaria, when your mast cell releases its histamine and mediators, akin to nettle rash, which is normal. You can get lots and lots of bumps and wheals. People can get significant rashes, and they get erythema or redness or flushing. And that's with a significant amount of skin involvement. The next organ that's really quite affected for patients with indolent disease is the gut. We don't normally go and biopsy the gut. We do it to make a diagnosis or exclude something else. And so the same sort of swelling you're getting in your skin, you get in your gut. You don't see it. And that's what causes cramping, bloating, nausea, indigestion. And then some patients, when they have an episode, will suddenly find that they've got a lot of bloating, cramping, and then they need to go to the toilet. And some patients can have diarrhea up to 10 or 20 times a day. And then actually, the mast cell mediators actually are released and they affect the whole of the body, not just the organ they've been released in. And so they do cross the blood-brain barrier, and patients talk about not being able to think properly, not being able to focus properly, not being able to concentrate as much as they do. There are different ways, and it's under the generic term brain fog. And then you've got the liver or the spleen. In those patients of advanced disease, they get a big liver and a big spleen. So they may get some splenic pain as a result of that, or they have abnormal blood counts, which we know, so they'll get symptoms of tiredness or anemia or bleeding or bruising because of their abnormal blood counts. So it's really, really across the whole system, your whole body, and it can affect people in different ways. So skin-wise, it could be anything. It could be perfumed ointments. It could be certain materials, certain clothes, woolen clothes, could be heat. Very often we see that there's a change in temperature can affect some people. Some people get worse in the hot, some people get worse in the cold. So it is very variable for that particular patient. We tend to treat patients with antihistamines because we're not getting rid of those mast cells. So what we have to deal with, a little bit like hay fever and allergies, is deal with the fact that their mast cells have released this stuff, the mediators, the histamine, and you use an antihistamine to dampen the effect of what's happened at the time. Exercise-induced urticaria is common. So some patients will find they're okay until they get into start doing exercise. For the gut, predominantly food. We know that there is food in high histamine, and I wouldn't advocate a low histamine diet at this point, is what I'm going to point out. It's just because, high histamine foods are high tomato-based foods, very spicy foods, Mexican foods, Indian foods, foods that most people like. And in one patient, it will make a massive difference to their gut and they'll have significant symptoms. In another, they won't if they're taking antihistamines. So I think it is for the patients to find out what their triggers are, because everyone will be different. So I think we don't know what it's like walking in the shoes of a patient with systemic mastocytosis. We have all lots of data, and as a clinician, I'll never assume I understand because I'm not wearing those shoes. So if I can look at different things, so there's a survey. We did a PRISM survey across 7 European countries, looking at the impact of symptoms on their quality of life, on their work, on their emotional state, and just top level figures. There were about 574 patients, of which half of them suffered from indolent systemic mastocytosis, and that is the most symptomatic group. And 2/3 of them said that they had moderate or severe disease. That is disease that has an impact on their daily life, one way or the other. 66% of those patients found it difficult to get on with their activities in terms of work and employment. Over 50% of the patients also had problems with trying to balance that work-life balance, and it had an effect on their mental state or emotionally trying to manage that, let alone managing their own symptoms and their illness. But actually, a lot of patients, as you do when you have a chronic rare illness, is you deal with it, you get on with life, and you adjust how you approach your life depending on what you need to do. But I think what came to mind was how much impact their illness has on how they can actually manage at work, and the impact it has on the emotional, then has a knock-on impact on their relationship statuses within their family and their work colleagues, and how much they are actually carrying with them to try and function normally as to what society expects. And so we're uncovering a lot more in a more systematic way. But, for patients, there are patients with anaphylaxis. I haven't mentioned that before as one of the symptoms, but it is. Patients specifically with wasp or bee stings can get unexpected anaphylaxis. And anaphylaxis is a life-threatening event. It's shocking. So if you've had anaphylaxis once and then you get told you've got this disease, which is lifelong, and you might get anaphylaxis again, you're carrying that question mark about when, what do I do? So I think the burden of disease is underestimated. But we also know there are some patients who are completely fine. What we need to do is look at those patients who are very symptomatic and give them tools to manage their illness, deal with the situation they're in, both at family and at home and at work, because that's where we really need to make an impact as clinicians. Some patients are so symptomatic that their whole lifestyle has had to change to manage, including staying at home, in which case their partners or their family are then carrying out the other jobs, looking after the children, making sure things are fine. And that's to enable their loved one to be able to manage their disease. I don't think we talk about that. You know, I find out when I speak to my patients and they say, well, you know, I don't go out for 3 days. My mum comes over, she cooks the food for the children. My husband does it. He does a full-time job as well. And those are caregivers who are just, because they're caregivers, they're not caretakers, if you see what I mean. They actually love their loved ones and that's what they want to do. And then we've got folks who will go to work and they will function as much as they can and have 2 or 3 days wiped out. And they need to have somebody help them or manage the other things that we all need to do from time to time. And so the caregivers pick up a lot of that. And I think that, again, is unknown. I think the impact on the patient is something we need to find out more about, but the caregivers and what they need to do and what additional support they might need is also, which I think we've just seen the tip of the iceberg, really. When I see a patient, the first of all is the listening and understanding and acknowledging. You know, you need to get the patient's story. It's listening to the symptom burden across the breadth of the symptom burden, and asking about every system, because not all patients know that actually their gut, their skin, their brain fog, maybe it's all adding up. So first of all, is actually having a good consultation in the first visit and listening and acknowledging that, you know, some of those symptoms may be SM. I have to use this opportunity to say that SM is rare. So, and there are other medical conditions patients can have. So not everything will be SM. It's about sitting there and listening and trying to work out from experience what could be or couldn't. And that takes time. I ask them about their triggers. I always, even if I've met the patient before and their symptoms have changed or I haven't met them, I will ask every patient to think about their triggers, because we've got so many. For food, so I tend to say to patients, look, you know, if you're getting these flares and they're constant, think about it, put a food diary. Which days are worse? If you're having severe reactions, we need to think about what to avoid. And it's incredibly useful, because people start recognizing a pattern. And you have to keep a diary for 3 or 4 months, not a week or so. And people start recognizing a pattern, and then they omit or reduce or stop or change their medications. And then they see there's a change. And that's, I think, true empowerment for that patient, because I'm not there, we're not there. I think also the patient support groups, without a doubt. You know, we have an international group of patient support groups which are now linking up. It's sometimes nice, I think, to have somebody who understands you as a patient. You know, you can be as empathetic a clinician as you wish to be or you can be, but you're still the doctor. And it's nice to talk to somebody else who either might be going through the same thing or understands it from a patient perspective. Every single patient is unique, completely unique. And so it's about that patient understanding their illness and us supporting them with how to manage that. That there's a spectrum from those that have indolent, non-advanced disease and advanced, and they have very different outlooks and different therapies available. And that there is a patient support group and a network of clinicians who are engaged, who are very happy to continue the support that we hopefully give to try and make life better for these patients.